Hi. Good morning. I'd like to welcome everyone to Grand Rounds. Real delight for me to introduce my colleague, Dr. Huie Lin, who certainly many of you all know. He's going to give us an update on our adult congenital heart program, which he is the physician champion of. Completed his undergraduate training at Yale University, medical school training at the University of Virginia, and medicine residency as part of the Harvard Medical School system at Beth Israel Deaconess, and his interventional cardiology fellowship, including pediatric and interventional and congenital training at Washington University, part of the Barnes-Jewish and St. Louis Children's Hospital. So very, very well trained. He's taken the lead and is doing excellent work, and he's our go-to guy for congenital heart disease. So we're delighted for him to give us an update on this topic. Huie, thank you.
Well, great. Thank you, Jerry. Well, obviously, this is a topic that's near and dear to my heart, and it's really my passion. And hopefully, you'll see that we've actually done very well with it. As many of you know, we did not actually have an official adult congenital heart program until about 3 years ago. And so when we started, we had really no patients. And so I'd like to take a little bit of time today to show sort of where the progress has actually gone and major milestones that we've actually had. Unfortunately, what that does mean then is that I won't be able to actually talk about a lot of cases in a lot of detail, and this won't be a review of adult congenital heart disease. If we'd like to talk about that at some other point, I'd be happy to sit down and go over that at some point. So since there is CME here, I'd like to make sure that it's clear that, unfortunately, in adult congenital heart disease, most of our devices are used off-label. So you will see off-label use of devices. So in outline, what I'm going to talk about today is the scope of congenital heart disease and why we have an imperative here at Houston Methodist to develop and foster a program in adult congenital heart disease. I'm going to show you where we've gone in the first 3 years of the program, and I'd like to show some highlights of major things that have been absolutely huge in the advancement of our program here. And then I'd like to talk a little bit more about where things need to go going forward and where we think, as an adult congenital heart community, globally, the programs need to go. So this is a slide that I like to show, and I like to show frequently, and I like to show it over and over again. And the reason why I like to show this is because I want to show what this actually means for you and I. So what you see here is in dark gray is admissions to the hospital for adults with congenital heart disease, whereas in light gray you see pediatric patients with congenital heart disease being admitted to the hospital in absolute numbers. And as you can see, it rises pretty quickly when you look at the adults with congenital heart disease, such that in 2010 we're rapidly catching up. And in fact, at this point, we actually think that there are probably more adults than pediatric patients with congenital heart disease being admitted to the hospital. And that makes sense because it turns out there are probably 1.5 million adults with congenital heart disease, and that number is estimated by the CDC to increase 5% annually. Now, this is all estimated because, in fact, we have no official national registries for adult congenital heart disease, unlike many of the other countries that we often work with. So it's also estimated that it affects about 1% of all live births. And unlike most of the other cardiovascular diseases that we deal with, this is a lifetime of exposure. So we are now seeing patients live to a normal life expectancy, 6th, 7th, and even possibly 8th decades. And so if you think about that, what that actually means is that their exposure is 7 or 8 decades, and their burden on the healthcare system is 7 or 8 decades. So we often think then that it's going to be a tidal wave. So this probably doesn't mean a lot to most of you sitting in the room. But what I'd like to actually explain is why we actually think that's the case. I think probably the reason why it doesn't mean anything to most of you is because we haven't actually seen this happen, because they're sort of waiting in the wings. But let me show you why this is actually the case with a very simple analogy. So this is Mickey as the sorcerer's apprentice, and I like to liken this as once he's gotten that magical hat, that's where we were when we were able to start doing cardiopulmonary bypass in the 1950s, because prior to that it wasn't actually possible to operate on the heart, which means that if you were born with a cyanotic heart disease, you died within the first year of life. And if you had transposition of the great arteries, but you may have had some sort of shunt, you may survive the first few years of your life, or tetralogy flow, you may survive the first few years of your life, but you certainly didn't survive childhood. But going back a little bit further, even before Mickey got his magical hat, stealing it from the old sorcerer, was the Blalock-Taussig Thomas shunt. That really opened the door to actually being able to take care of these cyanotic heart disease patients, and that was in 1944. So the reason why all of this is really critical is because it actually tells us what the timing is of when these patients are starting to show up and why we have a tidal wave that's coming. So we all know where this is going, right? Once Mickey gets that hat, bad things start to happen because he starts to become powerful and starts to do things. So as you remember, Mickey was tasked to clean up the sorcerer's tower. And so what he ends up deciding to do is that he starts to enchant these brooms and buckets. And so with the advent of tetralogy of Fallot repair, we have now created a patient population that is automatically going to almost certainly need another cardiac surgery. And I'll tell you a little bit more about that in a minute. And then, of course, likewise, there was the advent of the mustard repair for transposition of the great arteries. And as many people in this room know, that can lead to severe systemic right ventricular dysfunction with a need potentially for transplant down the line. And so the buckets keep going and the brooms keep going, and sooner or later we start to have this problem, which is now we're actually allowing hypoplastic left heart patients to survive to adulthood for the very first time in history. And it's estimated now that there are more than 250 surgeries, the final Fontan surgery for hypoplastic left heart, being performed in the United States every year. And what that means is that sooner or later we're going to have to pay this piper, because in their 20s, these hypoplastic left heart patients do not do well. So that's the problem. And remember, at the end of the story, this is what happens to poor Mickey, and this is what's happening with all these pediatric congenital patients as they reach adulthood for the first time in history. We are going to be overwhelmed, and that's why we're actually talking about the tidal wave. To put it in another perspective, this is what we're talking about. So unfortunately, as I mentioned, we don't have these registries in the United States. This is from Canadian data. So in the orange, you're seeing the adults with congenital heart disease. And in the green, you're seeing the children with congenital heart disease. And we're talking about survival of all congenital heart disease. Now, when we just pick out the complex patients, it turns out that the children have actually plateaued, whereas the adults are increasing in survival, again, for the very first time in history here in the 2000 teens. And so now you can understand why we have a concern. Not only are we having more adults with congenital heart disease survive, we're having more complicated patients with congenital heart disease survive, including the single ventricle population. And that's why we have an issue. So let's talk about Houston. Let's talk about our good friend across the street, Texas Children's. What you're looking at here in the dark blue is from their annual report, from their annual surgical report for surgical cases done in their operating room every year on congenital heart disease. That's a lot of cases. So almost universally, since 2010, they've been doing nearly 800, possibly even 900 in 2014 cases. I'll just let that sink in for a second, okay? So we're talking about nearly 1,000 cases of congenital heart disease being done. Almost all of these patients are going to need some sort of follow-up down the line when they become adults. And unfortunately, what this means is these patients are being followed until the age of 18, at which point they're being cut off and being sent to adult practitioners, which means you and me, which means these patients are going to be coming in droves once they reach adulthood. So who is Mickey as we start to have this problem with the tidal wave? Well, it's probably not just pediatric cardiology, even though sometimes they decide to hold on to their patients into adulthood. It's probably not just family practice. It's probably not just general medicine. It's us, too, in adult cardiology and cardiothoracic surgery, right? So this is going to continue to be a problem for us as these numbers mount. And if you think about it, if we're having 1,000 surgeries done just here across the street, imagine what this number looks like nationwide. And imagine what role that puts us in as a potential referral center for all of these patients down the line as they show up in community hospitals around us, sick, because they haven't had their preventive care. So unfortunately, what that means is that we're not prepared for the success, as I mentioned. So basically, the patients are becoming more complicated. More single ventricles are surviving into adulthood. They're actually doing very well. But the reality is they continue to need preventive care throughout the rest of their lives. And so to give you another sense of the scale, this is what we're talking about. So in Houston alone, we have at least 40 pediatric cardiologists in active practice. Okay? So how many adult providers do you think we have that specialize specifically in congenital heart disease? And we're talking very busy pediatric providers. They take care of their patients for 18 years. On the adult side, we're going to have them for 50 to 60 years, I just mentioned. Plus, the other problem is that we're going to have to start dealing with acquired heart disease, because the reality is they will develop coronary disease, they will develop atrial fibrillation, they will develop heart failure, and they will develop peripheral arterial disease and hypertension, et cetera, et cetera, et cetera. So the reality is most of them are lost to follow-up. They don't make that transition, even though in the guidelines now it's suggested that patients need to begin talking about transition at the age of 12. They don't make the transition. So the vast majority of these patients are lost. How do we know? Well, it turns out that, that Texas Children's probably has only about 1,000 to 1,500 active patients being followed in the adult congenital world. That just doesn't make sense, right? Because if you have 1,000 patients being operated on every year, where are they all going when they reach adulthood? So we're missing a lot of them. And likewise, here at this point, we're having about 500 patient visits a year, so we're not getting them all either. So they're out in the community. They're seeing some of you. They're seeing some of our colleagues further out, or they're not seeing anybody at all. The reality is there's no dedicated program nearby. The closest dedicated program is the mature program is at UT Southwestern, okay, or at Ochsner in New Orleans. Otherwise, it's us. There's a program that's beginning to develop at Dell Children's in Austin, but it's a long way away from any major adult congenital heart centers. So here in Houston, we have 7 of us, okay? Probably more likely 5 of us that are truly heavily active. So at TCH, there are 4 adult congenital heart specialists. There's 1 here, obviously, as you know, and there are probably 2 at UT that are active. So clearly, there's a problem. There's a disconnect between all the patients that have congenital heart disease that are graduating from pediatric programs and the number of us that are prepared to actually engage and take care of these patients on a regular basis. But the problem at the end of the day is these patients are lost to follow-up, and you can imagine why. They're in their 20s, their 30s, and their 40s, right? And they think that they're invincible because that's what we all thought we were in our 20s, 30s, and 40s. And most of us probably didn't even have primary care physicians. So the new guidelines are coming out for adult congenital heart disease. And so to sort of frame what's going to happen, I wanted to show you where they're classifying congenital heart anatomy in terms of complexity. And this is very busy, and I don't expect you to look at this in detail. But the bottom line is this. The simple lesions are, of course, the things that you expect, which are small ASDs, small VSDs. The moderate lesions also include things like repaired tetralogy of Fallot. And then, of course, the complex lesions are the single ventricles, the Eisenmengers, the double outlet right ventricles. And I want to show that briefly because I want to show you what is being sort of mandated in the 2015 guidelines, which I had the privilege of being able to review. So obviously, please don't go telling people that I've got this and I'm showing you this, but this is what it is. So at this point, all classes are recommended to be co-managed with an adult congenital heart provider. All interventions should be performed in collaboration with surgeons and interventionalists with expertise in congenital heart disease. Diagnostic and interventional cardiac procedures in all classes should be performed in a hospital with an adult congenital heart program. Patients in the lower risk adult congenital heart classification must be evaluated at least once. Providers should consult adult congenital heart cardiologists to determine the level of adult congenital heart cardiac care required for any patient being admitted for acute care. That's even if they're coming in for a cholecystectomy. Administration of anesthesia for invasive procedures in adult congenital heart disease in all 3 classes should be done by or in collaboration with an anesthesiologist with the expertise in the management of adult congenital heart patients. Now, that's pretty burdensome, and I can't imagine how we would actually even accomplish that here at Methodist if you think about the numbers of these patients that are potentially going to be out there. And so the reality is that the ivory tower philosophy that we've operated based upon in adult congenital heart disease is not going to work. We really have to work as a team. So some of the work has to be done by adult congenital heart providers. Some of the work has to be done by the primary cardiologist. Some of their work is going to have to be done by a primary care physician. And we need to continue to work together in order to actually make this happen. And you'll see me continue to harp on that throughout our experience here. So what I want to talk about now is our experience over the last 3 years and how that's actually changed. So speaking of the traditional adult congenital heart program, most of them in the United States were born from children's hospitals. So most of the time it's a large freestanding children's hospital that has created a patient population of pediatric cardiology, and they know now they need to continue taking care of these patients once they reach adulthood. And so they generate an adult congenital heart program. But what that means is that everything that's done is done in the pediatric hospital, for better or for worse. Now, obviously, they have all the advantages of already having the infrastructure for congenital heart disease. So, for example, they have specialized dedicated cardiovascular anesthesiologists for shunt-type physiology. They have interventionalists that are trained in congenital heart disease. They have surgeons that do nothing but tetralogy flow repairs every day, right? So there are significant advantages to this. But on the other hand, in this university setting where most of the time this develops, what that means is it leaves the adult hospital in the cold. And it really only leaves a small relationship from the adult congenital heart program to the adult cardiologists and the adult hospital. And so what that ends up creating is a situation where there's a minimal investment in the adult hospital and a minimal amount of program development. So what we wanted to do here was to create a different system. And so using our hospital system, we wanted to generate from the adult cardiology population an adult congenital heart program. And you can see there that there's no official relationship yet with either of the children's hospitals. But because we have a continuous referral base anyway from our sister hospitals, our aligned hospitals, and then from aligned physicians, this becomes a situation where we become a major congenital heart program. And the reality is, as I'll show you in a minute, the patients are coming here anyway. So it behooves us to actually have a full-fledged congenital heart program. And then along the way, the nice thing about this is it doesn't tie us to either children's hospital mandatorily. And so we can continue to have these relationships with the children's hospital and generate referrals in that manner as they graduate from those programs without necessarily being tied to one surgical program or the other, or giving up the referrals for advanced procedures. So why would this work? Well, the reality is that the patients are coming anyway, and let me tell you why. So, not to say anything negative about any other program here in Houston, I want to actually take my experience in St. Louis. So I trained in the university environment. I trained in an environment where the congenital heart program was born out of the pediatric hospital. And here's why that doesn't work. This is the waiting room at St. Louis Children's. This is the waiting room at Barnes Jewish Hospital. Which one do our patients want to go to? It's pretty clear. And actually, if you ask many of my patients, they don't want to step foot near a children's hospital because if they had complex disease, they spent probably the greater part of their childhood in a children's hospital. So they have a lot of traumatic and negative memories of actually being in a pediatric hospital. In fact, one of my patients, I'm trying to get involved in one of the charitable programs for bringing congenital heart patients from outside the country. He does not even want to meet a child who's going to have congenital heart surgery because he's so traumatized and he can't handle that. So obviously there's a clear aversion to actually stepping into a children's hospital, and for those of you who have actually attempted to refer patients to Texas Children's or Children's Memorial Hermann, your patients probably balk. I know of at least one relationship that when Dr. Solomon and I have had to try to collaborate on a patient, that patient refused to go to Texas Children's Hospital for additional workup. And that's just the nature of these patients. They're not interested in stepping foot into Children's Hospital. And so what that means is they're coming to us no matter what. And actually, if you look at the UHC data, we had a number of tetralogy flow, transfusion in the great arteries, single ventricle patients showing up here at Methodist before we started the program, irrespective of whether or not we had a program. So it behooves us to have it anyway. And this is evidence of this. So the last time I was actually able to do this tally was during my first year here, and this is what the tally looks like. So this is our cumulative program by month. And so when you look at the map, this is what it looks like over the months of the first year. And these are where the patients are coming from. And you can imagine that this is a clear demonstration of what I told you at the beginning, that there are not congenital heart programs that are available nearby. And this is what it looks like now. So it turns out that we're getting referrals as far away as South Carolina. We're getting referrals as far away as China, Ecuador, Guatemala, Mexico, and even most recently Ethiopia. And it reflects our experience here at Methodist, right? We get these global referrals. We get these referrals from all over the United States because we are known for these issues. And it turns out apparently we're also known for congenital heart disease too. The reality is that the complexity continues to evolve. We don't get a chance to choose whether or not we take the simple patients versus the complex patients. Again, this is the last time I was actually able to table out the complexity of these patients. And within the very first year, you can see that the complexity of the patients has risen dramatically and actually astronomically, such that we even had single ventricle patients within the first year of our program here. So what I'd like to do next is I'd actually like to show some of those milestones in relation to those complex patients. So it turns out we have actually a pretty robust surgical program pretty quickly. My hope was to sort of wait on the congenital heart surgery early on as we were working out the kinks developing the program, but it turns out that the need drives what we do. And so what I want to highlight here is a couple of very exciting things. There are a number of collaborations that we did with Texas Children's and Dr. Fraser's group. They were really excellent cases in very difficult, complex procedures. Obviously, we have excellent surgeons here who have been great at helping us to set up this program. Likewise, most recently, we've started collaborating with the University of Texas, Bill Douglas, the pediatric cardiac surgeon there. And this summer, we were beginning to develop the program with a plan of doing some simple cases. And I'll tell you where that kind of changed. And then finally, one of the other things that I really want to highlight was that in August of this year, we actually had a transplant of a patient with transposition of the great arteries with systemic right ventricular failure done by Dr. Shiner and Dr. Suarez, and that was a great success. So as I told the transplant team, that was one patient being transplanted. But for me, that's a program building, tremendous paradigm shifting event, because what that means is that we are probably one of the only programs in Houston now that can effectively do transplant in complex congenital heart disease. And of course, as you can see here on the right column, we have a number of pending surgical cases. In fact, one of my patients is in the operating room right now getting her primum ASD repaired. And so what we expect is that this is going to continue to build, and within the next several months, we're going to do at least one cardiac surgery every month. Probably by 6 months from now, we're going to be doing 2 cardiac surgeries every month. And so the need is there. It's happening. And unfortunately, sometimes you can't predict what this complexity is going to be. So as I mentioned earlier, this summer we were trying to develop the cardiac surgical program for the congenital heart program by doing some softball cases. But what unfortunately happened was that nature throws you a hardball. So what happened in July was that we had a 22-year-old man who presented to Willowbrook Hospital. He was profoundly cyanotic. His saturations were in the 60s, despite non-rebreather. He actually had a genetic syndrome called Golden Heart syndrome. It's okay if you don't know it. The primary issue is that they often have airway issues in addition to their congenital heart issues. And it turns out that he had tetralogy of Fallot. He had a modified BT shunt done in Galveston as an infant. And then after that, he was lost to follow-up and had no other additional surgeries done. And so he was basically an unrepaired tetralogy of Fallot patient. And so this made us fast forward what we were going to have to do for the congenital heart surgery program, because try as we might, we couldn't get his saturations up. So we had him on BiPAP, and with that, his saturations were in the high 80s, low 90s. But other than that, we couldn't get him any better. So what we think happened was he effectively had a TET spell in the setting of having an upper respiratory illness, as often happens in our kids. So this guy sat in the ICU for about 2 weeks while we tried to medically manage them. But as you know, there's no way to medically manage a TET. So this is what happened. So I took him to the cath lab, and this is what we're looking at. This is his problem. So he has 2 major issues from his tetralogy flow. Number 1, he has subvalvular stenosis, as you would expect. And then, of course, his pulmonic valve is very small. And then the other problem that he has, and it's probably hard to see on the screen, but he has supravalvular stenosis as well. So this is not a problem we can fix with a catheter. At the end of the day, this kid needs a full tetralogy flow repair, or else he's probably not going to leave the hospital. And so to remind you what that looks like, this is what Dr. Douglas ended up having to do for us. Several months before, we were actually planning on doing something like this. So Dr. Douglas had to do an infundibular resection to remove those right ventricular outflow tract muscle bundles, as well as to slice across the pulmonic valve. In fact, actually, I think in this particular case, he used a homograft to actually replace it. But most of the time, the initial tetralogy flow repair in a child is done with a transannular patch, where they patch open the pulmonic valve and then patch across the VSD. So the great thing about this kid was he did fantastic. So he was extubated shortly thereafter, and while he had a slightly rocky course due to diastolic dysfunction, which often happens in these old tetralogy flow patients, he actually left the hospital and is walking around without the need for supplementary oxygen at this point. Unfortunately, he doesn't want to go back to Honduras at this point, so he's probably going to be lost to follow-up again until he has his next event, but hopefully we'll keep in touch with him this time. So the problem, though, with tetralogy flow, and this is going to transition to why we keep having tetralogy flow patients show up even after they've had their complete repair, is that when you cut across the valve and put a patch across it, you leave the patient with wide open pulmonary insufficiency. And that mandates that at some point in their life, they're going to need a valve replacement. They're going to need a pulmonic valve replacement. And so it turns out actually that even though the traditional teaching has been that pulmonic regurgitation is benign, it turns out it's not by the time you reach your 20s and 30s. And this is what your right ventricle will look like eventually. And so what we're looking at here is this is the right ventricle, this is the right ventricle outflow tract, and this is the left ventricle. Obviously, the left ventricle is not supposed to be teardrop shaped, and the right ventricle is not supposed to have to and fro flow into the pulmonary arteries. And so this is one of my patients who, at 36 years of age, presented with palpitations. So it turned out that he had sustained VT, and we ended up having to send him for an open surgical pulmonic valve replacement. And the preferred method these days is to use a bioprosthetic valve or a homograft if absolutely necessary. And as you can imagine, if we're doing this at age 36, there's going to be a problem down the line, right? So if you put in a bioprosthetic valve, sooner or later that bioprosthetic valve is actually going to fail. And so in a 36-year-old patient, that means that potentially in their 40s or even 50s, they're going to need a redo chest again, so that it will be redo chest number 2. And then if I just told you that some of my patients are surviving to their 7th and 8th decade, if they make it to their 70s or even 80s, that means they could potentially in their lifetime have 4 or even 5 cardiac surgeries. So that's where the transcatheter valve technology has been really huge in the treatment of these patients. And so this is the Melody valve, which is a bovine jugular venous valve that's placed on a platinum iridium stent and deployed by a balloon expandable device. And so just as with the Sapien valve, immediately after deflation of the balloon, you have an external competent valve. And you can imagine how this completely changes the game for these types of patients. In fact, actually this weekend when we had our adult congenital heart symposium and we were actually demoing the Melody valve for some of the patients and their families, I actually had a family whose parents actually wept at the sight of the Melody valve because they realized that their daughter may actually not need cardiac surgery in a few years as had originally been planned. So this is how it actually looks. So when we do our planning, this is 4D flow MRI, and I'll talk a little bit more about that. And this is a 3D reconstruction of a cardiac CT in one of my patients who has PA stenosis as well as pulmonic regurgitation as a result of a quote-unquote attempt at a valve-sparing tetralogy flow repair. So he has an enlarged right ventricle that's also hypokinetic because he has both pulmonic stenosis and pulmonic regurgitation. And the way we like to do this is we like to do a 3D reconstruction via a rotational angiogram on the table. So that way we can see the takeoff of the left PA and the right PA because all Melody valves are bifurcation lesion interventions. Because if you jail a PA with a Melody valve, that's catastrophic, as you can imagine. So this is the deployment of the Melody valve, and this is our final angiography afterwards. And you can see, obviously, that the valve is now competent, and we've actually opened up that stenotic area that you saw before. But the problem is sometimes these landing zones are not amenable to Melody valves. So how do we do this? And so this is a major milestone for us. So this is a 27-year-old woman from South Carolina. She'd had her initial complete tetralogy flow repair, but she'd been turned down for valve replacement at 2 other centers because she was a Jehovah's Witness and would not take a blood transfusion. And so she was felt to be too large for a Melody valve, but she was also felt to be inappropriate for open cardiac surgery because of her beliefs. And so what we did, because she was coming from South Carolina, was we took her a CT scan that she had done locally in South Carolina, a cardiac CT, and generated a 3D model from it. And then we validated the 3D model by doing a rotational angiogram in MIGHTY and comparing the 3D data set to her original CT scan to make sure that the model truly fit with the CT scan. And indeed, as you can see here in the bottom corner, that it really does. So as you can see here, that's the model, and in gold, that's the CT scan 3D reconstruction, and they fit perfectly. So from this, unfortunately, what we did find was that this was not going to be amenable with a standard melody valve approach. So if you look at the bottom bottom left-hand corner, this is a 24 millimeter balloon inflated in that model. And as you can see here, it's not fully opposed to the sides, which means that if we were to deploy the melody valve, it would probably embolize either into the left pulmonary artery or the right pulmonary artery. So then we had to think pretty quickly about what to do. And so what we did was we came up with a novel method for intervening on this patient without the use of cardiopulmonary bypass. Now, I don't think at this point that we were going to get away without actually doing a redo median sternotomy. So our hope was that if we were to obviate bypass, then perhaps we could actually save blood loss. So our goals were the following: to minimize blood loss, restore a competent pulmonary valve, and then to optimize the safety in this. And so with Basil Ramlawi, actually Basil Ramlawi did obviously the dissection. I can't dissect anything. He was able to do a very clean dissection in the reduced sternotomy and isolate the pulmonary artery. Once he'd done this, what he did was he created a felt band that actually had a piece of Raytec, a thread of Raytec woven around it. And that's going to be crucial, as you'll see in a minute. With that felt band in place, we actually created a landing zone by inflating that same 24 millimeter balloon across that right ventricular outflow tract. And now you see why the Raytec becomes important, because it gives us a way of aligning perfectly orthogonally to the right ventricular outflow tract and setting up our shot. Likewise, once we'd inflated the balloon, Basil was actually able to cinch down the felt band so that we had a perfect landing zone for our melody valve. So then once we did that, we actually did a pre-stenting with 2 bare metal stents and implanted the melody valve here via direct right ventricular puncture. And then once we did that, we had an excellent competent valve. And then Basil removed the sheath, closed the right ventriculotomy, and closed the chest. She was extubated that same day, and then she left the hospital 3 days later. At the same time, we were actually able to use a colorimetric assay to determine our blood loss, and it turns out that, according to that assay, she only lost about 28 cc's of blood, and in fact, her hemoglobin didn't change at all. So she did great, and this is actually her. She likes to tell her story. This is Allison, so we want to show her off. This is her a week later here in Mighty, as we showed her her 3D model and went through the whole case with her and showed her exactly how it worked out. And obviously, we miss Basil, wherever he is now. But the key thing to all of this, and I want to keep emphasizing this, is that we work as a team. We really need a team to actually make this happen. Some of the people, obviously, you see in the room at this point made this happen. But without actually working as a heart team, we can't actually do this. But I think we can continue pushing innovation as we continue working as a heart team. So these are our melody valve referrals so far. As you can see, we've done 8 melody valves. The last one was 50% successful. In full disclosure, I'll show you exactly what happened in that particular case. But as you can see, they're from all over the region, and we've done relatively well. So in full disclosure, what happened with our 8th melody valve was the following. So this was an on-label indication use of the melody valve. It was a patient with a Ross procedure, which means that she had a pulmonary homograft in position. She'd actually had a severely complicated post-surgical course after her Ross procedure 10 years ago. And so Eric Mendeloff, who was her surgeon, actually found that she developed a left coronary pseudoaneurysm around the reimplanted coronary due to what was thought to be endocarditis. And so he took her back to the operating room about a couple weeks later and spent 16 hours reconstructing the left coronary and reimplanting it into the neo-aorta. So obviously that was not a normal area and not a normal patient. So knowing this, we figured that probably the best option for her still at this point was probably to do a melody valve. And the on-label indication for use of a melody valve is implanting in a conduit such as a homograft, which was this case. Unfortunately, what happened was as we were doing our initial pre-dilatation, we ruptured into the left coronary. And it may be hard to see here, but because the left coronary was so complicated, in the aortogram what you see is you see flush of contrast going into the pulmonary artery. So you see the right coronary opacified, but you don't see the left coronary opacified because the left coronary is actually now bleeding into the pulmonary arterial system. So Dr. Ramchandani and Dr. Suarez bailed us out, brought the patient emergently to the operating room after we placed her successfully on ECMO, and saved the patient. They were able to do a successful vein graft to the left anterior descending so that they were able to repair the coronary perforation. They repaired the homograft and placed a new biprosthetic valve. However, initially she didn't come off of bypass, and so she was kept on ECMO for about a day and a half. However, when she was brought back to the operating room to decannulate, it actually turned out that the biprosthetic valve had now actually, the new pulmonary biprosthetic valve had now actually developed a 5 meter per second jet of stenosis. So there was early failure for whatever reason of the biprosthetic valve. So the reason why I say that this is a 50% successful melody valve is because ultimately what we ended up doing was through a direct RV puncture, we implanted a melody valve in the failed biprosthetic valve. So thanks to, again, the heart team, through this collaboration, this patient actually did very well, and she walked into my clinic just Tuesday to say how well she's doing. So likewise, we rely on the referral from our partners and our friends in the community. Coarctation has been an important part of the development of this program. And I want to tell you about a specific case to highlight how we actually interact with our partners in the community. So this is a patient of Mike Mitschke, who has actually Turner syndrome, and actually, as you can see here, has a coarctation of the aorta. So he sent her to me for evaluation. So I took her to the cath lab, and I actually found out that even though this coarctation looks fairly significant on the MRI, it turns out it's not significant hemodynamically. But she came in with chest pain, and that was her presenting complaint. And so the thought was perhaps she had an aneurysm or she had a severe coarctation. Turns out neither was really the case. So I asked him, should I go ahead and shoot the coronaries while I'm at it? Well, it's a good thing I did, because she has this, and that's the source of her chest pain. So this is the message that we try to tell our pediatric friends, and that is that at the end of the day, these are adults and they develop coronary disease. So in order to maintain our relationship, and because the patient is going to continue to follow up with Dr. Mitschke for her cardiology issues, I sent her back to Dr. Mitschke, and he actually did a PCI in his group. So that's the kind of relationship that we want to continue to build with our partners in the community. So one of the more complicated coarctations that we did was this. So this was a patient that was sent to me who had previously, at age 42, had actually already had a stroke. He had blood pressure of 250 and a 70 millimeter gradient going down to his lower extremities. And he was sent to me as a coarctation. Well, it turns out he doesn't just have a coarctation. He has a complete interruption of the aorta. So you can see here, this catheter is not going anywhere. This is the descending limb of the descending thoracic aorta. So what we did was we went from above, from the radial, in order to actually take this picture, to just see how far apart we were. So ultimately what we did is we looked at his CT scan to see what's going on, and it actually turns out probably what happened here was he had a patent ductus arteriosus that also involved the aorta, and when it involuted, it took the aorta with it, and that's why is this total interruption. So unfortunately what happens here is you can't do this like a CTO intervention. You can't go from beak to beak, because if you go from beak to beak, you'll end up in the left pulmonary artery, just like the PDA does. So then we were left with these decisions. Would you send the patient for cardiac surgery? Would you try to medically manage? That's obviously not going to work. Or would you try to fix it in the cath lab? And so we discussed this case with Dr. Reardon, and what we ended up deciding was because of all these, and you can see here in the intercostals and the internal mammaries, that a tremendous number of collaterals have developed over the lifetime of this patient, that this patient may be better suited with a percutaneous or transcatheter technique, because he's going to keep bleeding and bleeding and bleeding post-operatively from all these numerous collaterals. And and as a heart team approach, he was in the room when we did the procedure. He actually helped us with the case, and he was on as backup. So we did this in the Harvard operating room using this technique. So this is called the Baylis-Nikkinen RF wire. So this is a wire that we use that can generate an RF pulse and perforate through tissue. So we can set the energy to whatever we want to. And in this particular case, what its on-label use is for perforating through pulmonary atresia. So we plan to use this because once you stop the energy, the wire is very floppy and soft and will not be traumatic. So this is the distance. It's about 6 millimeters based on our 3D reconstruction. And so what we did was we did, again, an on-table rotational angiogram with simultaneous injection from above, from transradial approach, as well as from below, from femoral approach. And with help from Ponraj, our scientist from Siemens, we were able to create these 3D regions of interest to show the roadmap for us three-dimensionally. Because obviously on fluoroscopy, we can't see things three-dimensionally, but with this roadmap, we can get a sense of where we need to go. Because once you start burning, you can't change course. And what the critical thing that we wanted to do is we wanted to do this, right? We wanted to make the two ends meet. What we didn't want to do is do this, because that's how we end extravascularly or in the pulmonary artery. So that's what we did in the hybrid operating room so that if we had a complication, we could go on pump fairly immediately. So this is the perforation wire, and this is an angiogram. And as you can see, we're following this line of attack. So I say this is like watching paint dry. So let's move on to the next part. So once we got across, we were able to snare the wire and externalize it out the radial access site. And from there, we were able to create an arterial-arterial loop, giving us all the support that we needed to. So from there, we were able to put a stiff Lunderquist wire across and get our sheath across. And of course, once you get a sheath across, you're in great shape. So this is the sheath going from the femoral arterial access site out to the left subclavian artery. So once we're there, we can apply this technology. So this is an investigational device called the covered sheet and platinum stent, which is a platinum iridium stent that has expanded PTFE covering on it. And so once we had this across, we were able to deploy the stent, and it's really sort of anticlimactic at this point. But now we have connected aorta. So this patient did great. So after this, his blood pressure came down to the 120s the very next day on 2 medications. 6 months later, he's on no medications whatsoever for hypertension. As you can see here, he really has no gradient and certainly no diastolic continuation of flow, which is the true hallmark for coarctation. So again, I want to highlight the importance of actually having the heart team and how the heart team really made this doable. Because certainly without the help of having a cardiac surgeon in room, I don't know that we would have had the ability to actually do this procedure. So finally, I'd like to talk about the next steps and highlight multiple important issues that are coming up. So certainly, as you know, certification is now here. So adult congenital heart disease boards were last month, and so they'll be given every 2 years. Likewise, there's going to be program accreditation that's going to start happening, and actually we're going to have to apply sometime in 2017 for accreditation. I'll talk a little bit more about that. Next, I also want to talk a little bit about the program development and where we go forward from here. And then finally, I want to talk a little bit about the research that we're doing here in adult congenital heart disease as a preview for Michael Markle's talk next week. So it turns out that the major body in adult congenital heart disease is the Adult Congenital Heart Association here in the United States. It's the advocacy group and also really the group that helps to create education and awareness. And with their medical advisory board, they met in February already to begin planning program accreditation. And so the recommendations are actually starting to become concrete at this point. Of course, the objectives are the things that we all want, which is to optimize the quality of care for these patients. As you know, there's always going to be minimal criteria for how these programs can be accredited. Likewise, what they want to do is they want to start creating certification, quality metrics, and registry as well as a database so we can start learning from our patients more and more. So this is a long laundry list of what they're going to expect. And thankfully, we actually have some of these things in-house, and I'll show you how we've already worked on that. But there's a lot of things that we don't, like, for example, psychology, mental health, social services, cardiac rehabilitation for these patients. Certainly one of the major deficiencies that we have is reproductive health. We don't have transition services. But many of the other things we do have. So it turns out that what they're going to do is they're going to break it down to a comprehensive care center and an ACHD care center. So obviously, if you're a comprehensive care center, you're Tier 1. And if you're a ACHD care center, you're Tier 2. Obviously, we'd like to be Tier 1 if we can be. And of course, the goal of this is to create regional centers of excellence, just like everything else that we do, so that we can concentrate the care experience because these patients are rare, right? You don't want somebody who sees a patient like this once in a lifetime to be taking care of them if you can. You want to concentrate their care to promote the quality of these patients. And so what they used as a model was the grown-up congenital heart programs in the UK. And of course, in the UK, they have the National Health Service, so that way they can actually mandate these things. So they're very strict in the UK. This is how it turns out their model is built. So they have a local person, they have an intermediate person, and then they have their specialized centers, which have on average 4 adult congenital heart specialists, and they're expected to take care of 1,500 adult congenital heart patients. And this is the model that they want to build Tier 1 off of. So if we want to get to Tier 1, we have a lot of work to do. I think it's feasible, but we certainly have a lot of work to do. So at this point, we have a lot of strengths already, right? So we have an excellent pulmonary hypertension program, especially with Dr. Frost's program coming over. Now I have an excellent relationship with both Dr. Park and Dr. Ashworth, and they see a lot of my patients in partnership. Of course, already we have a number of patients going to the electrophysiology department because it turns out that many of my patients end up developing ventricular tachycardia and need work from that standpoint. Dr. Suarez doesn't have a picture. I think it was probably a casualty of the changes in the website recently, so unfortunately he's not here. But of course now the transplant program has transplanted successfully a congenital heart disease patient, and I think that this is a tremendous boon for our patients. Because of course, as with many cardiac diseases, all roads ultimately lead to congestive heart failure and potentially the need for transplant eventually. And of course, Dr. Reardon and unfortunately Dr. Ramlao is not here anymore, and Dr. Douglas have, as well as many of the other members that I mentioned before, are a huge part to the success of our program and will continue to be developing that program. But that's not all. Of course, there's plenty of other things that we really need. Of course, the ICU has been a tremendous help. Of course, we have started identifying nursing champions from the standpoint. We will need help from a social support standpoint. And of course, there are more things that we will need to develop over time if we truly want to have a program. So furthermore, what we really need to do is to learn from our patients, because the reality is that these patients are totally different. They're like you and me. They work. They have kids. They need to pick up their kids from daycare. They need to actually work out time off from work. So we can't just say, well, you know, you're going to sit and wait for your echocardiogram for about 3 hours in the waiting room before you can get it done. I'm sorry, you're just going to have to take the whole day off. They get penalized $10 an hour if they're late picking up their kids from daycare. So what we had this weekend was the Adult Congenital Heart Symposium, so that we could bring together our referring physicians, our patients, and their families, and talk about what's coming up in adult congenital heart disease and how can we take care of them better. Indeed, part of the accreditation for our congenital heart program is going to be having a patient and family advisory board for every accredited congenital heart program. And so from this group, we will actually develop our advisory board who will help us to understand how do we take care of this very specific population, because they're different from most of our other cardiovascular disease patients. So this is what it looked like. So this is here in Mighty. This is a family actually learning about the melody valve from our TDS, Juan Olano, who actually turns out is a cardiac surgeon. They actually got to do a cath. So some of our patients actually tried out the AngioMentor simulation suite. This is our team that helped us out. This is one of my friends from St. Louis who actually now moved to Dallas to take care of congenital heart patients, Ari Cedars, who came to speak for us. And then, of course, this is the program itself. And so this is what it looked like on the second floor of the Research Institute. We actually had a great turnout. We had about 90 people show up for the event, so pretty spectacular for the first time out. Finally, what I want to talk about is a little bit about the research that we're doing, and this is 40-flow MRI. So obviously we all know that the right ventricle is a very complex structure, and understanding how exactly it begins to fail in congenital heart disease is a very complex matter. And so it turns out that that 40-flow MRI may be a way to actually start to look at that. So here are two different types of volume overload. In the first, you see the normal patient, and the second one, you see the secundum atrial septal defect. And then the third, you'll see the patient with tetralogy of flow and severe pulmonary regurgitation. So one of the things that we've actually learned from 40-flow MRI is actually turns out that some of the tricuspid inflow actually goes directly towards the right ventricular outflow tract during diastole already, instead of thinking that it just goes into the right ventricle. And in fact, it actually turns out the efficient flow is very much part of that. We think that as the right ventricle fails, that component starts to drop off. So likewise, you can see here that that component is actually preserved in the patient with the secundum atrial septal defect. And one of the major things that you see is that there's increased flow, just as you would expect with that left to right shunt through the atrial septal defect. There's now increased pulmonic flow. Whereas now you can see where things are completely disrupted due to the pulmonic regurgitation. So you can see that there's outward flow and then regurgitant flow that's sort of spreading outwards throughout the entire right ventricle, in addition to the fact that the right ventricle is gigantic. Now, what's chicken, what's egg? What happens first and what happens second is unclear. But what we can see is very clear now is that that tricuspid inflow is no longer doing that efficient turn upwards to the right ventricular outflow tract, because, of course, during diastole now you have the pulmonic regurgitation jet that's shooting towards the apex of the right ventricle and spreading outwards. So we think that this is going to start to give us insights into how the right ventricle begins to fail in congenital heart disease. And likewise, this is another one of my patients who actually had a very interesting 40-flow MRI. So she had also severe pulmonic regurgitation, but as a result of that, her right ventricle dilated as well as did her tricuspid annulus. And what you can see here is what's happening with that severe tricuspid regurgitation. So late in the jet, you actually see that it's beginning to migrate upwards into the SVC. And if you actually fractionate out the SVC flow in red and the IVC flow in blue, you can actually see that the SVC flow is extremely inefficient. It's really not getting into the right ventricle, except for just a few particle traces. So I think that we can start to learn more about the mechanism of how these patients start to get sick from their right ventricular dysfunction from 40-flow MRI. And so, like I said, this is just a tasting of what this is going to look like, because Dr. Markle, who's sort of one of the major champions of 40-flow MRI, will speak on this next week. So finally, one of the things that's really exciting that we're just about to start to do is interventional MRI. So interventional MRI is really a myth. It's kind of science fiction, because there's no way we can actually do any kind of intervention in cardiac MRI at this point, because we have no devices for that. What it turns out is you can actually take the lowly Swan-Ganz catheter, you can fill the balloon with gadolinium, and you can now visualize it under cardiac MRI. And so that's what this is. So this is real-time cardiac MRI, and this is a balloon-filled catheter that's floating through the right ventricle. And what's great about this, of course, is that you can get all three planes simultaneously, and so that's what this is here. So you can actually get 2 planes, 3 planes, however you want, and you can actually change the saturation in order to actually see the catheter better or less. And what's great about MRI is you can actually see the cardiovascular structures as you work without the use of contrast. And so obviously this is still very early in development, but one of the great things that this is going to bring to the table for our patients is that we will be able to get true empiric pulmonary blood flow calculations, as opposed to using the assumptions that we use with FIC or thermodilution. Likewise, if we have a catheter in the right ventricle or the pulmonary artery, we will actually be able to get pressure and volume simultaneously. And so you can also think of where the applications for this may be. If we're actually trying to understand the pulmonary blood flow changes that occur with a nitric oxide challenge, this is where we can determine it empirically, as opposed to using a lot of those assumptions that we normally use in the cath lab. So I want to leave you with this. The bottom line of what we're actually trying to do now is we're trying to move away from the ivory tower philosophy that many of us sort of grew up on, coming from the adult congenital heart community. We can't just sit in place, expect people to send us patients, and then take the patients and keep them. We need to continue to work with our partners out in the community, both primary care physicians, primary cardiologists, et cetera, et cetera. We need to continue sending them back, and we need to continue working together, because there's just too many patients and too much work to do that's coming around the corner. There is a tidal wave coming, and we're actually going to have probably more of these patients than many other places in the country, because Houston was a major cardiac surgery center in the 60s when a lot of these patients were born. And so in order to survive childhood, many of these patients actually had to move to the Houston area, and so their entire families came here, and so they settled here long term. So we're going to have more of these patients than many other places in the country. And then finally, proactive and preventive care in these patients, just like everything else that we do in cardiology, is absolutely critical, because if we don't, they're going to have catastrophic consequences. And so together, I believe that we can work to reach out to these patients. And I'll skip through this. So it turns out that we are all going to have to work together to create healthcare access. We're going to all have to work together to reach out to these patients, because they're out there. And together we can find them, we can bring them back to care. The key thing that we need to always remember, as Carol Warnes likes to say, is that these patients have never been normal a day in their life. So they don't know what asymptomatic means. So whenever you see one of these patients, be suspicious of asymptomatic. So with that, I'll end, and I'll just leave you with a few of the pictures from our event this weekend. Thanks.
Huie, thank you for that tremendous talk, and obviously for the efforts you put in and the expertise you have brought to our group, and certainly under the umbrella of transplant. We're 1,000 times better with you, and certainly than without you, and I'm sure that our colleagues feel the same. Let's jump right into questions. Dr. Winters.
Huie, that's a remarkable story. I remember a conversation a couple of years ago we had about the development of an adult congenital heart program, and this is extraordinary. I have a question in regard to the registry issue. You say there are no registries in this country. The American College of Cardiology has a number of registries which have been quite successful. Is it conceivable that working through them, a registry of this sort could be established?
Yeah, that's a great question. So just to give fair credit, Dr. Winters was one of the first people I turned to when I first got here to talk about how to build a congenital heart program since he's been here. So the problem, of course, is that you have to get all the centers to cooperate, right? And that's been sort of a little bit of a problem. And then, of course, you have to talk about, well, who's going to actually take credit for it? So, and then finally, the other major problem is it's really complicated building a registry for congenital heart disease because it's so heterogeneous. What repair do they have? Who did it? What are the differences between the repair that they had? What are the complications they're going to have based on the different differences that they actually had in their repair? And so the initial step to that was actually to do the impact registry, which unfortunately we're not yet part of. The impact registry is to look at congenital heart interventions. And they've defined very exclusively what those are. So the only interventions that they're actually looking at are atrial septal defect closures, coarctation interventions, et cetera, because what they wanted to do was create a clean study to begin with. Now, there's been a lot of complaints about that because there's a lot of missing data from that. That's the initial pilot. From the other end, what's happened is that the CDC has selected 3 major cities, and unfortunately, they didn't end up selecting Houston recently, to start looking at pediatric congenital heart disease and following these patients lifelong, so that way we can get a sense of epidemiology and then access to care, et cetera, and all the things that we talked about today. Unfortunately, what that means so far is that we don't have anything that's nationwide. I do think that the ACC would be an excellent source, I think, in conjunction with the Adult Congenital Heart Association. I think it's going to be a lot of money. I think it's going to be a lot of effort, and it's going to be a lot of people arguing for years about how to do that. But I think hopefully we can look forward to that eventually down the line. I do think it's probably going to require federal funds to make happen, though. So once we get the motivation to do so, I think we can get there.
Huie, again, I think congratulations on all the efforts, and we're glad that you're on board to help out our efforts, and especially for transplant, congenital patients don't do well unless you have a strong team. My question is related to some aspects that we sometimes see in heart failure. A lot of these adult congenital patients are probably with adult cardiologists who might not be essentially trained in adult congenital. And sometimes we see this in heart failure, you don't know what you don't know. And there's always this culture of holding on to patients. Now, is there data in your world to look at outcomes for being followed, because there are subtle things that you watch for, and then when you have them spread out in so many physicians, you know, how do you propose in getting referred at what time?
Right. So to answer the first part of it first, so a colleague of mine and I from University of Arizona, we're actually going to mine the UHC database to get at that question. So if you were sent to, say, a program that has an adult congenital heart program, did you do better? Did you use less resources? I think, unfortunately, what it's going to boil down to is we're going to be looking at specifically things like tetralogy flow repair or pulmonic valve replacement for tetralogy flow, because those are the things that you can actually quantify in UHC. It's not going to get out all outcomes, right? It's going to be a little bit hard from that standpoint. I think the reality, though, is it's going to take something like a registry to really get at that question. So that data doesn't really exist just yet. What we do know is that from formal surveys from the ACC, it turns out that probably about 70% of patients are not getting referred to adult congenital heart specialists. And so I think, you know, that's why there's such an impetus in the 2015 guidelines to say you must refer at least once. But I understand where they're coming from, right? I mean, I think that, not naming any names, but there are programs here in Houston that don't send the patients back. And so I can understand why they're reluctant to do so, right? I mean, this is a neat patient, right? I mean, they can talk to you about their careers because they're at the same stage of life as you are, and they're probably one of the only patients that you have with this complex disease. So it's kind of fun to actually maintain these patients. So we want to maintain that relationship. So I think one of the crucial burdens on our part is to make sure that our referring physicians understand that we are going to continue to work with them. We are going to continue to send them back.
So Huie, so you've obviously built a very strong program in a very short time. Comment on sort of your success or challenges with philanthropy, because I would say this is a very sympathetic target, particularly in this city. So working with foundation, you know, what's happening with philanthropy, and what would you spend money on?
Wow, that's a great question. I think the first part of it is I think everybody likes the story. I think it's a fantastic story, right? I mean, it's a very exciting story to think that, you know, now these kids are actually surviving into adulthood. And everybody likes thinking about that kid that probably got surgery when they were a kid they knew in school, right? Because everybody knows somebody with congenital heart disease. That's the reality. But unfortunately, I don't know that that has necessarily translated to us for philanthropy, and so I think that that is a significant challenge. I do know that there are probably particular people that we can work with to get there. But I also think that the other major challenge is that we haven't identified, just like you said, what exactly we want to fund. So I think that probably in my mind, the major opportunities are probably going to be things like education, okay, education and awareness of the patient population, right? So the ability to actually go out and do outreach and actually educate the population about congenital heart disease. Because as I mentioned, if it's 1% of the population, everybody's got, I mean, somebody's got it. Somebody that you know has it. So that's certainly one opportunity. I think if we could find a way of actually putting it on paper in a way that we knew was going to get funded, I think the other opportunity is we need nursing help. I think we need to identify people who are actually going to be specialized in adult congenital heart disease because, let's face it, I mean, we're paralyzed if we don't have that. We see it on a daily basis here in a lot of our patients. I think just going through the lesion, explaining what's happened, what the surgery has been about, and then what are the goals for their care is a constant challenge, just like you probably had with the VALVE program as it was going along. So I think that those are two major opportunities that I would really like to see if we could actually get there with philanthropy. But the other part of what we're trying to do with the Patient and Family Advisory Board is we're hoping that they will help us to go out and to seek philanthropy too, because when they tell their story, it's even more compelling. When their mom shows up with pictures of the baby in the ICU, and then the patient shows up with 6'2", 260 pounds, and can leg press 1,000 pounds, it's pretty cool. It's a pretty great story, right? So I think that our patients can help us to push that too.
Any other questions? Thank you again.
Thank you for the opportunity.